COVID-19 pandemic, it's impacting and changing the O&G services in Uganda. The picture displayed before is of a woman agonizing for the loss of her loved ones. A mother and her unborn child died. The cause of death is strongly related to the aftermaths of COVID-19 pandemic lockdown. With the COVID-19 pandemic, our government implemented strong travel bans. This saw a cessation of normal operations of our basic, cheap, effective, efficient transport means. For instance, at the top right-hand corner is a picture of a ferry. This ferry connects mainland Masaka to island Kalangala or Sese Island. So during the COVID-19 pandemic, this ferry could not operate. It prevented clients seeking O&G services from the mainland, particularly surgical services, from accessing these services. Surely, though not on record, some may have died, though others may have tried to use other means like speedboats or boats, the normal canoes, to reach mainland for surgical services. The picture at the top left-hand corner is for a rider and a woman as a passenger. We call that border transport. That is a very easy, cheap means of transport. It helps us reach almost everywhere, including enabling pregnant women to access health facilities. All these means of transport could no longer operate. The drivers or sailors or riders would fear getting infected by the passengers, and even the passengers would fear getting infected by the riders or sailors. So this meant that some of our clients could not seek O&G services normally. They either gave up and delivered at home with complications we are yet to discover, or lost their lives. Some had to brave long distances to health facilities because walking alone was believed to be the safest means of transport. But this had very bad outcomes. With inability to access the skilled health workers at the facilities, some of our clients sought care at our former ally, the traditional birth attendants. And we all know research has shown that there is strong association of the work of traditional birth attendants with poor outcomes of maternal health care. This is a glimpse of what the O&G workforce in Uganda is struggling to change. Ignore the week 1 up to week 3 and start looking at between week 4 and week 37. I'm not saying that it's because of COVID-19 that we are having high perinatal deaths or high maternal deaths. But COVID-19 is a novel factor that we really need to consider. We need not to ignore it. It could have serious effects on our efforts to reverse this trend. Relaxation of the lockdown has come along with some hope. We could, to a certain extent, see some of our clients. The picture before is of health workers receiving a pregnant mother from a motorcycle. But there is a lot of fear. Health workers fear the patients. Before, patients could fear health workers, but now health workers are also fearing the patients. The fear for the patients have for health workers has even increased because they now think that they could get the coronavirus from health workers. Even health workers think they could get the coronavirus from the patients. So that fear, they are working in fear. Depression alone is also another factor, particularly for the workforce, a big chunk of the workforce in private not-for-profit health facilities. These facilities rely on the contribution of patients who come to seek their services. Now managers of these health facilities have to make very difficult decisions regarding management of financial resources. They have to think of whether to buy protective equipment or to pay health workers. And they also have to look at the mere resources available, since most of our clients were not coming to the facilities. Like I said, it is not COVID-19 alone leading to the bad outcomes of maternal health care. There are so many other things, and we were slowly learning these things, and we were doing something about that. For instance, skills training and practice. Before they were carried out like I'm doing in the picture on the top left hand corner. That's me in a yellow shirt delivering a didactic training on how to deliver shoulder dystocia to a group of trainees. And the picture below is from my colleague, a lady in a flowered dress delivering a didactic training on how to manage a shocked and unconscious pregnant mother. Then we thought it was cheap and enjoyable and effective to learn that way. But now this may no longer be practical. We need to think of other ways. IT is one of the ways that is available, because currently I'm comfortably without fear talking to other people, and I'm also going to learn from other people. Other people may learn from me, I'm also going to learn from them. But we're all away. I'm here in Uganda, others in the UK, all over the world. But this has also its issues. For instance, network coverage is a big challenge. I've struggled for days to connect fully to the Hopin platform. You could see me by text, but hopefully it really works out well. Otherwise, you have to share and hear my voice using this style of communicating through the YouTube. We need to strengthen the community health facility linkages if we are to remain relevant as a O&G workforce in Uganda. This means research. Of course, research has been something very good in helping us solve problems. In the same way, we needed actually to start embracing IT for continuous professional skills practice as early as yesterday, because research has shown that it is really fundamental in helping the O&G workforce to contribute to reversing the trend of poor maternal health outcomes. Thank you very much.